Price controls for Medicare prescription drugs will just pass along costs of drug innovation to non-Medicare patients, could lead to socialized medicine. Hello, this is Robert Romano, Vice President of Public Policy with Americans for Limited Government, dailytorch.com. Hit that subscribe button. Today we're going to be talking about President Donald Trump. He is considering an executive order that relates to a 2018 proposed regulation from the Center for Medicare and Medicaid Services that would regulate the price of Medicare prescription drugs under Part B, that would utilize, instead of what they call the average sales price, would use the International Pricing Index. The problem with this is that it's going to include foreign price controls and socialized medicine countries into the mix, such that we'll be reducing the costs to taxpayers and to patients for these prescription drugs. But what ends up happening because of price controls is that the costs simply get passed on to the next person. In this case, it'll be non-Medicare patients who will have to shoulder the burden, I believe, for these price controls. And this could be a mistake that President Trump is making here. He hasn't issued the executive order yet, but the Federal Register, this proposed rule has been around since October of 2018. And so the executive order would presumably be directing CMS to follow through with this regulation or something substantially similar. And again, I believe this is going to come at a significant cost to non-Medicare patients who are going to have to basically bear the burden. And how do we know that? Because the United States is already bearing the burden for drug innovation, the cost of it for the rest of the world. They use similar price controls, and then in turn, they're passing along the cost for developing new drugs onto the United States. And therefore, we end up paying more than the rest of the world. According to a Commonwealth study from 2017 on international price comparisons, quote, one reason U.S. prescription drug prices are higher may be the relative lack of price control strategies. Unlike the U.S., many other countries employ centralized price negotiations, national formularies, and comparative and cost-effectiveness research for determining price ceilings. In the U.S., healthcare delivery and payment are fragmented, with numerous separate negotiations between drug manufacturers and payers and complex arrangements for various federal and state health programs. And in general, the U.S. allows wider latitude for monopoly pricing on brand name drugs than other countries are willing to accept. So by driving, I believe, the costs down overseas, they're passing on those costs here. And that was as noted in a study in 2019 by Joseph Fair, Liam Seagod, and Steve Posiask on how international reference pricing for prescription drugs would hurt American citizens and consumers. And what they found was that, quote, one reason that pharmaceutical prices are so high in the U.S. is that the U.S. is subsidizing the rest of the world in the development of drugs. Drug development is costly, and other developed countries should pay their fair share of these costs. Indexing U.S. prices to those in other developed countries will not solve this problem, since other countries will not increase their prices to pay their fair share, and the result will be less pharmaceutical innovation, including for American consumers. Now, looking at the regulation and what CMS is proposing here in terms of how they're going to do Part B drug baseline costs that appear in the Medicare program, they're going to take what is called the average sales price under the current system and switch it over to an international pricing index. And so what this is explained in an HHS paper, quote, under Part B, providers and suppliers buy and bill these types of drugs. Since 2005 for physicians and 2006 for hospital outpatient departments, Medicare has paid suppliers and providers based upon the average sales price for each product, as reported by manufacturers to the Centers for Medicare and Medicaid Services. Physician offices that buy and bill Part B drugs are paid 106% of the drug's average sales price. Depending on a hospital outpatient department's participation in a safety net drug pricing program, Hospitals are reimbursed at either 106% or 75.5% of the average sales price. Now, the ASP, the average sales price, is reported by manufacturers to CMS as the total sales to all purchasers minus the price concessions granted to these purchasers and eventual end users, i.e. physicians and hospitals, with certain exceptions. For example, manufacturers may offer a rebate to physician specialists to prescribe and administer their product over competitors. The sale of the product to a wholesaler and the price concession granted to the physician are both accounted for in the average sales price. However, purchases and price concessions or rebates offered under federal discount programs such as the Veterans Health Administration, the Medicaid Drug Rebate Program, and state supplemental rebate agreements, and the Section 340B Drug Discount Program are excluded from the average sales price calculation. So that just tells you what the existing law and regulation are saying. What President Trump and the CMS are now proposing is to move over to this international pricing index. And this aims to keep the costs of Medicare down, both to patients and taxpayers. CMS has estimated that the proposed rule will cut Medicare spending by $16.3 billion over 5 years, and federal and state programs $1.6 billion for Medicare and Medicaid dual beneficiaries. So that works out to about a $3.6 billion average cut over 5 years. So every year it's going to be $3.6 billion on average that's cut out of the Medicare budget. But even if the purpose is to reduce senior out-of-pocket costs, and or the federal spending burden on taxpayers, by importing the foreign price controls, that money will surely have to come out of somewhere else, as the cost of life-saving medicines will simply be passed on to non-Medicare patients in the form of higher drug prices. And this really calls into question what is going to be the outcome here. Politically is going to happen here is that Democrats are going to say that, see, Medicare reduces prescription drug costs. Therefore, in order for everyone else to have lower prescription drug costs, we're either going to have Medicare for all, as has been proposed by House Democrats, Nancy Pelosi and Joe Biden, House Speaker, and the Democratic nominee, presumptive for president. They want to do the public option. According to Joe Biden's campaign website, quote, as in Medicare, the Biden public option will reduce costs for patients by negotiating lower prices from hospitals and other healthcare providers. So there you go. He wants to do a public health insurance option like Medicare. So either Democrats are going to do Medicare for all, or they're going to do something substantially similar to Medicare, and they're just going to do these price controls everywhere. And then really the question becomes, who pays for drug innovation? Either way, Democrats can bill socialized medicine as a means of reducing out-of-pocket prescription drug costs that non-Medicare patients will be burdened with under the CMS rule. So you cut the prices for Medicare patients, and then the drug companies, the money for innovation is going to come out of somewhere. Research and development for new drugs, so they're just going to bill it to the private insurers for now. Because if the Democrats regain power, they'll probably want to do socialized medicine, either Medicare for all or the public option. Now, according to a revised 2016 study from Joseph A. DiMasi, Henry G. Grabowski, and Ronald W. Hansen, innovation in the pharmaceutical industry, new estimates, and R&D costs. What they do is they take a look at the cost of developing a drug. And most recently, that amount was $2.6 billion pre-capitalized per approval. So for every new drug that's brought to market, per approval is about $2.6 billion in 2013 dollars. With the post-approval R&D cost, the estimates increased to $2.9 billion per drug that's brought to market. So to get through FDA and to get something out there, to develop something, it costs $2.9 billion altogether, especially for these new brand name drugs that are going to be patented, because companies, in order to basically afford to develop new drugs, they have to protect their intellectual property. And so you're going to have patents associated with that. So if it costs $2.9 billion for a drug, then they're going to have to charge $2.9 billion at least to make it worth their while, just to break even. And then if you're talking about private companies, so they actually have to earn a profit. So they're expecting, their shareholders are expecting that they're going to make money by selling drugs. And if they don't make money, then guess what happens? You're not going to have drug innovation anymore. And so what the federal government via CMS is saying is that the cost for research and development will no longer be subsidized by Medicare, the program that arguably needs those drugs the most. That's where seniors are going. They're the ones who are taking much of the prescription drugs that are prescribed, particularly for diseases that are not prevalent in younger people, but certainly are for the elderly. Now, the understated impact of price controls, unfortunately, is when the rest of the developed world uses them. Not only are they not paying their fair share, they are passing on the cost to us. And so I liken it to the situation that the U.S. finds itself vis-a-vis NATO. President Trump famously in 2016, he said, you know what, NATO's not paying their fair share of defense spending. They should increase how much they're supposed to be paying because they're not meeting up with the NATO treaty. And so President Trump has sought to rectify that, and I think he's been successful in bringing NATO on board to this idea that security of the Western world is a shared responsibility between the United States and Europe and our allies. And so therefore, we're going to have our NATO allies pay what they said they would pay in the first place. And so with prescription drug costs and the cost of innovation, all the other countries that are using price controls right now, I don't think that's really fair to the American people. And all the countries that are using price controls that are going to be included in this international pricing index, Austria, Belgium, Canada, Czech Republic, Denmark, Finland, France, Germany, Greece, Ireland, Italy, Japan, Netherlands, and the United Kingdom, they already are using price controls. So they're saying, you United States, American people, you pay for the cost of drug innovation. We'll just get them on the cheap by using price controls. But if everyone did that, there ain't going to be any drug innovation. So in a similar vein, instead of passing the higher cost for prescription drug costs to non-Medicare patients, as under the CMS rule, maybe a more equitable solution would be to get with the G20, President Trump, and, negotiate a trade deal or something like that, a treaty, or even just an executive agreement where these other countries are going to start to take on some of the cost of drug innovation. Why are we expected, the United States, to spend the lion's share of money on research and development? It makes no sense. We have a global market, but it's not behaving as such. It's a price-controlled market overseas. And so if you're an American drug innovator and researcher and developer, and you're going to produce these medicines that save people's lives, you have to make money on it. So you end up having to charge the American people for that, the lion's share of the cost of the research and development. And I'll leave you with the close here. In addition, given the high cost of bringing drugs to market and the situation we now find ourselves in with the Chinese coronavirus, COVID-19, a thorough reform of the Food and Drug Administration approval process is long overdue. We need to speed up that process the same way we did in the fight against AIDS in the 1980s. The Reagan and Bush administrations streamlined FDA approvals for AIDS drugs so that we could get more cures and medicines that could make AIDS not deadly. And eventually it succeeded, that where AIDS is not a death sentence. And a large part of that was because the FDA processes were approved. Well, maybe they should do that for the rest of medicines. Maybe we need to speed up the approval process, and that will reduce the cost to bring a drug to market. And that can help bring down costs in the long term. The last thing we want to do in the age of COVID-19 is stifle innovation among prescription drug developers when we need it the most. That's the commentary. This is Robert Romano, Vice President of Public Policy with Americans for Limited Government, dailytorch.com. Hit that subscribe button, ring the bell for notifications, and have a good day.